Hello, everybody. Welcome back to the Incubator Podcast. We're live at Hot Topics in Neonatology in Washington, D.C., and I have the pleasure of having in the booth Julie Raskin. Julie, welcome to the podcast.
Thank you so much, Ben. It's a pleasure to be here.
You are here representing a lovely organization called Congenital Hyperinsulinism International, which you'll tell us all about, abbreviated CHI.
That's right.
And we were just discussing off air the impact of hyperinsulinism and how it can be quite a devastating disease. So this is something that you contributed to after your own personal experience with your son. Can you tell us a little bit about what that initial experience was like and what the course looked like for you and your son?
Sure. So, out of the blue, my son Benjamin was born with a rare disease. It wasn't something we expected, but it was congenital hyperinsulinism. He was born in 1996. And unfortunately, it caused a brain injury because he wasn't diagnosed when we were at the birthing hospital. And so we went home, and then there was a break in care. So he was quietly, kind of silently, having this prolonged, very dangerous hypoglycemia.
Yeah, because I think that when we talk about hyperinsulinism, I think that these are sort of the questions I was asking you off air, is that we tend to think of the prototypical question that the doctors are asked on the exam, usually a baby that's beyond the bounds of growth, either a large for gestational age infant or a very small for gestational age infant. But it's not necessarily, hyperinsulinism does not necessarily affect only these individuals. It does also include patients who are born perfectly well grown and perfectly well adapted for gestational age, and that can be sort of a very difficult pathology to detect when the index of suspicion is so low because these risk factors are absent.
That's exactly right. We actually have a poster here that's about this very issue, and we have a registry, and this is a natural history. It's patient reported, and from our registry, we know that 28% of babies, when we look at the risk factors retrospectively, didn't have the risk factors.
Right.
So they didn't fit into that. But there's a problem with diagnosis even for those who did have risk factors or do have risk factors. Those babies may get a blood glucose test, but they may still go home. The the hospital or the NICU may decide they're okay,
Mhm.
and then they go home and there's a break in care, and then they too can suffer prolonged hypoglycemia. So we're on a mission to change all that.
Yeah, I mean, we know for the trainees that are listening to us today, I mean, hyperinsulinism and prolonged hypoglycemia, especially untreated, can have long-lasting consequences. And so, congratulations to you, because to transform this experience into advocacy and into meaningful change sometimes can feel like a natural progression, but it's very difficult. So I wanted to commend you for that. And I'm wondering, when it comes to the organization, who are you surrounded by? Who are the other people that are leading this effort?
Yeah. So it is a phenomenal, fantastic organization. And I have to say, it's very healing to be able to take something that was so difficult and has been so difficult and try and do something really good
Hmm.
for other people. And we have a whole wonderful community of people. So the organization, we have a wonderful staff, and we've hired scientists who help us to lead our research studies. And we have people in communications so that we can help raise awareness. We have wonderful advisors. We have clinicians and researchers from leading centers around the world. We have 8 centers of excellence that we have designated, 2 in the United States,
Wow.
yes, and 6 in Europe. And we have a wonderful board of trustees. You know,
And obviously, parents.
parents are at the heart of this. Parents are at the heart of this. And we have a global community of parents, an army of parents who are trying to change screening practices, who are behind helping to support research for new treatments with biotechs.
Yeah.
Yeah.
So I guess I'm putting myself in the position of somebody who's listening to this episode of the podcast, is in the car and is saying, okay, I'm all ears. What are some of the advances, some of the things that you've learned thus far that you would like every clinician to know, or maybe even adjust practice in order to not miss patients with
Sure,
hyperinsulinism.
sure.
So where are we at in terms of what could we derive from the work you guys have done this far?
Well, we have a wonderful campaign, and it's called Glucose is a Vital Sign.
Mm,
So when a baby is born, we believe that every baby should be screened for this disease so that no baby falls through the cracks, because you can live with this disease. And the thing is that over time, it can actually get better and better and better. So it begins in a very complex way. It's hard to diagnose and it's hard to treat, but it is diagnosable and it's treatable. So we must do everything we can. So I would tell clinicians to go to congenitalhy.org. That is our website, and learn about the recommendations. There are these fantastic guidelines that were created by an international group of clinicians to guide the treatment for this disease.
hmm
And there are diagnostic principles and hypoglycemia guidelines, and they're all on our website. And we work with fantastic neonatologists and pediatric endocrinologists to try and make change and ensure that more and more babies do not have brain damage that is absolutely preventable.
Congenitalhy.org. And glucose monitoring as a vital sign is a very innovative and interesting approach. Is there a specific time point in which you are recommending? I mean, not you specifically, obviously, but the group is recommending checking a glucose level. Is it something that should be done immediately after birth? Do you advise as a group that maybe a certain amount of time should have elapsed before checking? So what is the specific of that?
Ben, that is such a good question. And it's a complicated answer. So, first of all, we believe that we have to find those answers through research. So, we actually have three different interesting screening research projects that are either beginning or there are protocols and we're seeking funding. So we're looking into checking glucose plus ketones sort of throughout those first few days so that we can see where we can find that point at which healthy newborns are not going to get over medicalized, but where we're going to catch every single baby with this disease.
Yeah, and when we are sticking the infant for a lot of variety of
Exactly.
things, including in the US, the newborn screen. So it
Exactly.
feels like a pretty low hanging fruit in
That
terms of just getting one more drop.
Well, that exactly. So that would be that's something we should absolutely do. Get a wet blood spot when we're getting the dried blood spot.
Yeah, absolutely.
Yes.
Well, thank you for coming and sharing the work that you're doing with Congenital Hyperinsulinism International. Can you tell us a little bit what you're looking forward to at the conference this year?
Well, the main thing I'm looking forward to, we have a booth here and we have a poster. The main thing I'm looking forward to is really understanding the neonatologist and how the neonatologist approaches these babies. We can't make this change unless we understand what practice is now and how neonatologists are treating and thinking about the babies and the issues that are on their minds.
Hmm
So that is the number one for me. I went to such an interesting session today on genomics and looking forward to, screening babies for all sorts of diseases and looking to do that so that the results get back earlier and earlier. Because
hmm
for us, that's the issue there.
Absolutely.
There are over 30 different genes that can cause congenital hyperinsulinism. And then 50% of babies, we don't yet know what the genetic cause is. So we also need more genetic research.
Yeah, and just for clarification, the people who are listening, we're not talking about an infant of a diabetic mother who has a transient
Well, we're
hyper.
concerned about those too.
But
Yeah,
those have the benefit of, like we were saying earlier, to be well captured by the system because of these risk factors. But there is patients without these risk factors who have hyperinsulinism, who are chronically hypoglycemic, that need immediate intervention.
absolutely. Absolutely. We're also concerned about those babies that have transient
Mhm.
because often those babies can have transient for quite a long time.
Yeah,
So they don't necessarily only have it for a day or two.
yeah,
There are babies with perinatal stress hyperinsulinism, and they eventually get over it, but they are also at risk
yeah.
for brain damage. So we're very concerned about all these babies with transient, with persistent. Yes, all babies.
Julie Raskin, thank you so much for dropping by and congratulations on this.
Thank you so much, Ben.
Thank you.